Thank you for joining us this evening for our Prostate Conditions Education Council educational series. Tonight, we're joined by Dr. Garrett Pohlman. Dr. Pohlman is a urologist with Kearney Urology Center in Kearney, Nebraska. He received his medical degree from the University of Nebraska College of Medicine in Omaha and completed his internship right here with us in Denver, Colorado at the University of Colorado School of Medicine. Dr. Pohlman is also the host of the Prostate Health Podcast, featuring weekly interviews with experts, innovators, and leaders on prostate conditions. We'll list the website where this podcast can be found at the end of the webinar. You can also find a link to it on the PCC homepage. It's an excellent webinar and listened to not only by patients, but also many of our health experts. I want to remind everyone that you're welcome to submit questions throughout the webinar by utilizing the Q&A function at the bottom of the screen, as well as through the other formats you've been provided. We will share them with Dr. Pohlman after his presentation. Thank you so much for joining us, Dr. Pohlman, and I will turn the floor over to you.
Well, first of all, I would like to thank Wendy, and as well as Lindsay and the rest of the Prostate Conditions Education Council team for all you do. PCEC continues to be a national leader in increasing awareness and education on prostate cancer, current treatments, and men's health issues. It really is an amazing resource for men and those that care for them. So for tonight, I'm going to be giving a talk on the evolving prostate cancer landscape, which will be an overview of prostate cancer, or a prostate cancer 101. So the objectives for this evening are to provide really an update in the advances of diagnosing prostate cancer. We'll give an overview of the primary treatment options in men with localized prostate cancer, but also for men with advanced prostate cancer. So the prostate gland is located just below the bladder in men. The urethra, which is the tube that drains urine from the bladder, actually passes through the prostate. As the prostate enlarges with age, it can cause outlet obstruction of the urine flow. The prostate's primary function is to produce the majority of the fluid for the male ejaculate, which helps nourish and transport sperm. Prostate cancer can develop in the gland when cells in the gland mutate and grow in an unregulated fashion. So 1 in 9 men will be diagnosed with prostate cancer during his lifetime. With early detection, we are saving lives. Detecting prostate cancer at an early age or early stage offers the best hope, with the 5-year survival rate at nearly 100%. Now that drops to 28% if it spreads to other parts of the body, which is why prostate cancer screening and early detection is so important. And we need to give a lot of credit here also to PCEC, which has led the way in helping save lives by increasing awareness among the general public about the importance of early detection. Prostate cancer is even more common in African Americans. Not only do African American men have the highest incident rates in the world, they have the highest mortality rate. So prostate cancer is the most frequently diagnosed solid cancer in U.S. men. During 2020, close to 192,000 new cases of prostate cancer will be diagnosed in the United States. Prostate cancer is the second leading cause of cancer death in U.S. men, just behind lung cancer. So several risk factors are associated with a higher risk of developing prostate cancer, including age. The risk of prostate cancer increases rapidly in men over 50 years of age. In fact, 60% of all cases of prostate cancer are diagnosed in men greater than 65 years of age. Prostate cancer occurs more frequently in African American men and Caribbean men of African descent compared to men of other races. And prostate cancer is more common in North America, Northwest Europe, Australia, and the Caribbean islands compared to other regions. Now, the difference in this risk may be partially explained by the availability of more intensive screening programs and lifestyle differences. The risk of prostate cancer is higher in men with affected relatives, suggesting that prostate cancer has a heritable component. The risk of developing prostate cancer more than doubles for men with an affected brother or father. However, most cases of prostate cancer in men are without a family history. Now, several gene changes appear to raise prostate cancer risk, but likely account for a small percentage of cases. Now, this is where we get into talking about germline or inherited mutations, looking at mutations in the BRCA1 and 2 genes, which have the function of helping repair damage to DNA. And we'll get into that a little bit later in the talk here today. And some other risk factors which may potentially contribute to some somatic mutations, including diet, obesity, and smoking. So there usually is not any warning signs for prostate cancer. Early prostate cancer is usually asymptomatic, which is why the PSA and prostate cancer screening is so important. More advanced prostate cancer may cause symptoms such as slow or weak urinary flow of stream, blood in the urine or semen, or bone pain. Most of these problems are likely to be caused by something other than prostate cancer. However, it is still important to tell your healthcare provider if you are having any of these symptoms so that the cause can be found and treated if needed. So prostate cancer screening should be undertaken after a risk and benefit discussion between the patient and provider. As far as when to start, depending on which guidelines you use, I personally like the NCCN guidelines, which recommends early prostate cancer detection at age 45 and starting at age 40 years old for African American men or those with germline mutations. So prostate cancer screening involves a prostate-specific antigen or PSA blood test, as well as a digital rectal exam. Now the PSA is produced by cells in the prostate and is mainly found in semen, with a small amount also present in the blood. It is prostate-specific, but not prostate cancer-specific. So if you do not have a diagnosis of prostate cancer, some of the various causes for an elevated PSA can be from enlargement of the prostate, inflammation or infection, but also prostate cancer, which is why it still remains a great test to aid in the early detection of prostate cancer. It really is a great check engine light for men. And the levels of PSA correlate with the risk of prostate cancer, with most healthy men having PSA levels below 4, and increasing levels of PSA above 4 being associated with a rising risk of prostate cancer. The DRE or rectal exam is used to palpate changes in the prostate gland. However, the anterior portion of the gland is not palpable in the exam. Despite the limitations of DRE, it is included as part of prostate cancer screening because it may find cancer in men with normal PSA levels. The diagnosis of prostate cancer is usually pursued on the basis of an abnormal rectal exam or an elevated PSA. So the diagnosis of prostate cancer can only be made with a prostate biopsy, which may contain samples of a dozen areas in the prostate and sometimes more, and is sampled using guidance with a transrectal ultrasound. Current NCCN guidelines suggest a PSA of 3 or above as far as having that discussion about a potential biopsy. The role of MRI is evolving for prostate cancer detection as well. Most frequently now used, the MRI for men that have already had a negative biopsy, but now also it is now also being considered even before the initial biopsy to see if there are any lesions which could be targeted on the biopsy, in addition to the typical systematic biopsies taken. So prostate cancer markers are really making an impact on the world of prostate cancer by helping individualize patient care in the early detection, diagnosis, and treatment choices for prostate cancer. So the PSA has received a lot of bad press over the years. Now, we've already talked a bit about the PSA and that it's not a perfect test, but still, what we know is that now in the PSA era, we have seen a significant decline in prostate cancer death and men being diagnosed with advanced prostate cancer. So in looking for prostate cancer markers to help individualize patient care, we're looking for markers that improve the performance of PSA, help decrease unnecessary biopsies, as well as enhance detection of significant cancer. Also enhancing risk stratification of newly diagnosed prostate cancer patients, and really helping determine who is best suited for surveillance versus intervention, as well as determining which patients with advanced cancer would benefit from additional hormonal therapy or chemotherapy. So for those of our listeners that have not visited the PCEC webpage, it is really a great resource to men and their loved ones. They have an excellent section on prostate markers, including this graph. There have been a variety of different prostate markers developed by different institutions and companies that look at each person's genes or biomarkers and help determine individual risk for various scenarios, and we're really able to group them into different buckets. Some of these tests in helping determine if an initial biopsy is needed, including the PSA, 4K score, select MDX, and PHI score. Now, for men who have already had a negative biopsy and you're needing to determine who to repeat biopsy, you also have confirm MDX and PCA3. And we also have markers and tests for determining who to treat for prostate cancer with the Oncotype DX, Prolaris, and Decipher tests. And the Prolaris and Decipher can also be utilized after a prostatectomy in determining who may benefit from additional treatment, such as radiation. And lastly, genetic testing, which may play really an important role in identifying who's at risk for certain disease, who is at risk for more aggressive disease, as well as determining the best and most effective treatment options. So when we talk about prostate cancer staging, we are looking at the tumor staging as well as the Gleason score. So here's the TNM staging. There are three components which involve tumor, nodes, and metastasis. So for the T staging, so if you're a T1 or a T2, the prostate cancer is thought to be within the prostate, with the T1 having no concerning palpable nodules or firmness on rectal exam, or T2, where we are starting to detect palpable findings on digital rectal exam. T3 is where there are areas of cancer just outside of the prostate, and T4, the cancer has grown into other nearby tissues such as the rectum and bladder. The next level involved spread to the lymph nodes, that's the N, and lastly, metastasis or M, which is cancer that is spread to distant sites such as bony involvement, lung, or liver. So the Gleason score is the grading system used to determine the aggressiveness of the prostate cancer. The grading system can be used to choose appropriate treatment options. Pathologists grade prostate cancer using numbers from 1 to 5 based on how abnormal the cells look under the microscope. Pretty much all biopsy samples now are graded 3 or higher. Since prostate cancers often have areas with different grades, a grade is assigned to the 2 most prominent areas on each biopsy. Then these 2 grades are added up to yield your Gleason score. So for example, if we were primarily seeing Gleason pattern 3, but also some smaller amounts of pattern 4 on the microscope, that is a Gleason score of 3 plus 4 equals 7. Or if we're only seeing pattern 3, the score is just a 3 plus 3 equals 6. Now the lowest score again that you can typically get is a 3 plus 3 equals 6, and the highest score is a 5 plus 5 equals 10, being more aggressive. Now there's a new way to grade prostate cancer called the grade group system. This system is a more simplified grading stratification system with grades 1 through 5 going from the least aggressive up to the most aggressive, and was created to help better represent low-grade disease and reduce unnecessary treatment of less aggressive, more indolent prostate cancer. So grade group 1 is Gleason 3 plus 3 equals 6. Then you can see they separate out the Gleason 7s with a 3 plus 4 equals 7 falling into grade group 2, whereas a 4 plus 3 equals 7 is a grade group 3. Grade group 4 is a 4 plus 4 equals 8, and grade group 5 is Gleason 9 to 10. So imaging is really playing an increasing role not only in the detection of prostate cancer, but also in assessing for prostate cancer progression. Again, ultrasound is utilized primarily for prostate biopsy. But as I had mentioned, we continue to advance with MRI, now being able to incorporate an MRI ultrasound fusion biopsy to help target any suspicious lesions noted on MRI. The MRI can also be utilized after diagnosis in determining the extent of disease and for any obvious extracapsular extension. The CT and a bone scan have long been traditionally used for initial staging, indicated for unfavorable up to very high-risk disease, and some with favorable intermediate risk being candidates to get a CT and bone scan. And lastly, we are continuing to advance with PET scans, especially for men with recurrent prostate cancer, with the goal of being able to detect small areas of prostate cancer which could be missed by other types of scans. We are now finding that genetic testing is not just for prostate cancer. So genetic testing is important when you have prostate cancer if you've been diagnosed with a high-risk prostate cancer, or you've been diagnosed with prostate cancer that is considered advanced or has spread outside the prostate. If you have a first-degree relative, that is a mother, father, brother, or sister that have been diagnosed with ovarian cancer, breast cancer under the age of 50, pancreatic cancer, prostate cancer or Lynch syndrome, or it's also important if you have a BRCA1 or BRCA2 mutation. So when we talk about BRCA genes, this stands for breast cancer associated gene. Most people think about it, again, in relation to breast cancer, but they can also be linked to men's prostate cancer risk. The BRCA1 and 2 genes normally function in repairing cell damage and keeping our cells growing normally. But when these genes become mutated, they no longer function correctly. Those with an inherited mutation have an increased risk of prostate cancer and may also be at risk for more aggressive forms of prostate cancer, which tend to develop at a younger age and possibly more likely to become metastatic. And a genetic counselor becomes a valuable resource in this situation in guiding men and their families. And we'll get into this a little bit more at the end of the talk as far as treatment and how this can also play a role in precision medicine for those with metastatic disease. Again, as I mentioned before, if you haven't checked out the many PCEC resources online, make sure to check it out at prostateconditions.org. From there, you can also link to their sponsored website on prostate markers or access it directly at prostatemarkers.org, where you'll find useful information regarding prostate cancer markers, genomic tests, and genetic testing. So for the last half of the talk, we'll get into treatment options for prostate cancer for localized and advanced cancer. Now, prostate cancer surgery dates all the way back to 1867, where the first partial prostatectomy was performed by Theodor Billroth in Vienna. The first radical prostatectomy was performed in 1904 by Hugh Hampton Young at Johns Hopkins. Now, one of the more major breakthroughs in the treatment for metastatic prostate cancer was by Charles Huggins in 1938 for his discoveries concerning hormonal treatment of prostate cancer, and was ultimately awarded the Nobel Prize for his work in 1966. And we'll get into that here in a bit. Now, in the 1980s, LHRH agonists such as Lupron came onto the scene as an alternative to surgical castration. The first nerve-sparing prostatectomy was in 1983 by Dr. Patrick Walsh. Then really over the last 10 years, there has been an explosion of new therapies available, including the first immunotherapy for prostate cancer with Provenge in 2010, and now numerous more options for men with metastatic prostate cancer. So this graph here does a nice job of mapping out the natural history of prostate cancer, with this curve reflecting prostate cancer volume and activity. So after this first little blip, we see the prostate cancer responding nicely following surgery and radiation therapy. Now, some will unfortunately have a prostate cancer recurrence following initial treatment, and this is where you will see a surge in prostate cancer activity. This is where we can implement hormonal therapy, also known as androgen deprivation therapy, where we can drop that testosterone level to very low levels with medication, such as LHRH agonists. These therapies are quite effective and can be for some time. And this is where we are still in what we call the hormone-sensitive phase. But eventually, the prostate cancer cells can get smarter and become what we call resistant to the low levels of testosterone, called castrate-resistant prostate cancer. And we really see this curve then start rising upward again as the prostate cancer starts to become more active. Now, early on, men have no symptoms, but with time, symptoms can develop. Then we can also start visualizing the cancer on X-ray in the bones, for example. So for men who are first diagnosed with prostate cancer that is localized or not spread beyond the prostate, they have several treatment options, including active surveillance, surgery to remove the prostate, or radiation therapy to kill the cancer cells. Now, the majority of men respond to treatment at this stage, but at some point the cancer may progress for some men. So again, depending on a man's risk stratification, they may still have these three main options available to them, including active surveillance, which again is actively monitoring the disease to treat only if and when the cancer warrants treatment, surgery, where again we're removing the entire prostate surgically, as well as often some of the surrounding lymph nodes. It's most commonly done with the robotic-assisted laparoscopic approach, but there are still some open radical prostatectomies being performed. And lastly, radiation therapy, where we're either external beaming in radiation with external beam radiation to the prostate, or putting radioactive seeds or brachytherapy into the prostate, or a combination of these two radiation treatments. Now, other options include cryotherapy and HIFU, but as far as the main evidence supporting the treatment is for surgery and radiation therapy. But we continue to gain more data on these additional therapies, but also hormonal therapy for high-risk cancers and in combination with radiation therapy. So there's various types of radiation, external beam radiation therapy, initially starting off as 3D conformal therapy, but then as technology improved, we began to have intensity modulated radiation therapy, image guided radiation therapy, stereotactic body radiation therapy, and proton beam. Now, the majority of radiation in the United States is being performed either through the IGRT or SBRT. Now, with the SBRT, you're delivering larger doses of radiation over a shorter period of time. So you're looking at 2 weeks compared to 5 to 6 weeks with the more traditional approaches. Often, treatments are named by the machines that deliver the radiation, such as CyberKnife. I'm often asked about proton beam therapy. It's a newer type of radiation therapy that uses energy from positively charged particles called protons. It may cause fewer side effects than traditional radiation, but the evidence is still limited for cancer outcomes when directly comparing this to our traditional approaches for radiation therapy. It's also more expensive and not widely available in the United States. We'll be now moving into treatment options for advanced prostate cancer. What we are talking about here is prostate cancer that is no longer confined to the prostate and is spread outside of the gland. As we had mentioned earlier, around 1940, Charles Huggins showed that the course of the disease can be affected by hormones. He discovered that if the production of male sex hormones is prevented through castration, or if female sex hormones are added, the cancer could be suppressed. So again, when we suppress a man's testosterone to very low, or what we call castrate levels, this is defined as a testosterone level less than 50, and it is responding, it is what is called hormone sensitive. With the androgen deprivation therapy, we are suppressing the prostate cancer activity to very low levels. For many men, this therapy will prove to be effective for many years. But for some men, will unfortunately develop castrate-resistant prostate cancer, where the prostate cancer cells become smarter and figure out a way to thrive in the absence of testosterone. And when that happens, we have additional therapies we can implement for these men. Here's another breakdown of the prostate cancer journey. For those with localized prostate cancer confined to the prostate, again, can undergo definitive treatment with curative intent with surgery or radiation therapy. But if ultimately develop a PSA recurrence, can undergo salvage treatments if the cancer is still localized, such as salvage radiation or salvage surgery. Now, once it is indicated to start androgen deprivation therapy and the cancer is responding to therapy, the cancer is classified as hormone-sensitive prostate cancer. Once the cancer becomes resistant to that therapy and begins becoming active again, but we are not seeing it on any scans yet, it is called non-metastatic castrate-resistant prostate cancer. Now, once the cancer is detected in the body outside of the prostate on imaging, for example, in the bones, we now call it metastatic prostate cancer. And it can be either metastatic castrate-sensitive prostate cancer, where it still is responding to hormonal therapy, or metastatic castration-resistant prostate cancer, where the cancer is now starting to grow and thrive despite hormonal therapy. So in detecting advanced prostate cancer in men on hormonal therapy, we'll first start to see the PSA rising. We will then want to check the testosterone level to verify that we are getting the levels of testosterone below 50. We will also get scans to see if we're able to visualize the cancer. Some of the more common initial scans, including a bone scan, but other imaging options, including a PET scan that may be able to detect cancer not visualized with more common imaging techniques, is becoming more available. We also look at the PSA doubling time, which calculates how rapidly that PSA number is going up. So again, some of the basic concepts. Again, ADT or androgen deprivation therapy, again, we use this to treat prostate cancer. It lowers the male hormone testosterone. Testosterone is an androgen that fuels prostate cancer, but does not cause prostate cancer. Hormonal therapy can be effective for many years, but it can also stop working where the cancer becomes smart and develops ways to produce its own testosterone. And again, the goal of therapy is to maintain those levels of testosterone less than 50. And again, ADT is really the foundation for advanced prostate cancer patients. So who is a candidate for androgen deprivation therapy? Well, we use it at the time of diagnosis of metastatic prostate cancer. It can be used with radiation therapy to help the radiation therapy work for localized prostate cancer. And this is typically anywhere from 6 months to 2 years. It's sometimes used to help reduce the size of the prostate prior to brachytherapy for large prostates. And it can be used for treatment failure for localized disease. So some of the various options for androgen deprivation therapy: surgical castration, also known as an orchiectomy, and removing the testes, which is an irreversible form of hormonal therapy, and it's often not utilized. And also the same with estrogen therapy. Now, the mainstay of ADT has involved the use of LHRH agonists. Now, these are shots which can be administered and can block testosterone production by the testicles without having to remove the testicles. Following initial administration of these agents, you can get an initial testosterone spike or a flare. Where this is important to be aware of is in men who have already been found to have cancer in the bones. Now, that initial flare can cause problems, including possible pain, so they can be given oral medicine called anti-androgens prior to the initial shot to help block that flare. There are also LHRH antagonists, such as Firmagon, that also block testosterone production, but you don't get that initial flare in testosterone. And that's because they bind to the LHRH receptors and don't cause an initial release of LH or FSH. But one downside is that there are not currently any longer formulations available for this medication, and these require monthly injections. Now, lastly, we have several newer agents available for advanced prostate cancer that work a bit differently in manipulating testosterone, but you still need to be maintained on traditional androgen deprivation therapy for them to work. And we'll cover those other agents here in a bit. So men on hormonal therapy need to be closely monitored. We will be monitoring their PSA closely, as well as follow-up imaging studies where indicated. And maintaining bone health is very important. One of the possible side effects of hormonal therapy include bone loss or osteoporosis. It is typical to often obtain a baseline bone density scan and then periodically recheck that as well. We also recommend supplemental calcium and vitamin D to achieve adequate levels, including 1,200 milligrams of daily calcium and 600 to 1,000 international units of vitamin D. But it is also very important to keep close follow-up with your primary care provider, who can also help in closely monitoring the patient as well, including monitoring blood pressure for diabetes and evaluating for stroke and heart disease. Some of the side effects of hormonal therapy are listed here, including but not limited to hot flashes, which may potentially get better or go away with time, loss of sexual drive, fatigue, osteoporosis, loss of muscle mass, diabetes, cardiovascular disease, depression, and memory issues. While being maintained on hormonal therapy, in addition to bone health we just mentioned, it is also important to maintain a healthy weight as well as regular weight-bearing exercise. You also want to make sure you are keeping up a healthy diet. We typically say what is good for the heart is good for the prostate. So androgen deprivation therapy is highly effective and can induce a PSA decline in over 90% of patients. However, given sufficient time, some patients with hormone-sensitive non-metastatic disease will progress to castrate-resistant metastatic disease despite hormonal therapy. It is estimated that 10 to 20% of patients diagnosed with prostate cancer will go on to develop castrate-resistant prostate cancer within 5 years of follow-up. Castration-resistant prostate cancer, again, where the prostate cancer gets smart and figures out how to grow and thrive despite testosterone suppression. Again, this is where we see a rise in PSA despite hormonal therapy. It's either non-metastatic, where no visible spots of cancer throughout the body are showing up, or metastatic. And this here is a bone scan where we unfortunately see spots of metastatic prostate cancer throughout the skeleton. While there is currently no cure for metastatic prostate cancer, over the last 10 years, we have fortunately had an increase in the arsenal of available treatments in treating advanced prostate cancer. We have immunotherapy, chemotherapy, and radiopharmaceuticals, which we'll get into here in a bit. There are also now agents that utilize the androgen pathway targeting, including abiraterone or Zytiga, which is used with prednisone. Abiraterone inhibits the enzyme that is required for androgen biosynthesis. There are multiple sources of androgen, including the testes and adrenal glands. However, in metastatic prostate cancer, the tumor itself can be an additional source of androgen production. So this agent inhibits androgen production at 3 sources: the testes, the adrenal glands, and the prostate tumor itself. And we also have enzalutamide, also known as Xtandi, which is an androgen receptor inhibitor. This interferes with the connection between androgens and androgen receptors, which can also slow cancer growth. Again, as we are getting into utilizing some of these newer therapies, it is important that we still maintain a castrate level of testosterone therapy. So men will still need to stay on ADT, whether that is Lupron or whatever you are taking to keep your testosterone level suppressed. Now, the newest treatment includes DNA repair agents. And this is also where we get into that precision medicine again, where men with the genetic mutation BRCA1 and or 2 may respond well to what we call PARP inhibitors, such as rucaparib and olaparib. The PARP enzyme plays a role in DNA repair and can block the DNA damage response in these cancers with the BRCA1 and or 2 mutations. Now, by blocking this enzyme, DNA inside the cancerous cells is less likely to be repaired, leading to cell death and possibly a slowdown or stoppage of tumor growth. There is chemotherapy available for metastatic castration-resistant prostate cancer with the use of Taxotere. Some providers wait until the patient is symptomatic or has failed some of the other newer therapies, but there is some data suggesting that starting the chemotherapy at the initial diagnosis of metastasis with ADT may improve outcomes. Now, since 2010, immunotherapy has been available with Sipuleucel T or Provenge. With this therapy, a patient's own immune cells are collected during leukapheresis. These cells are then sent off to a facility where the cells are cultured with a protein that contains an antigen called PAP. This antigen is expressed on more than 95% of prostate cancer cells. And it's also cultured in with a cytokine that activates the immune system. So then these cells are then shipped back to the patient for infusion. And upon infusion, these activated cells help the immune system target and attack the PAP antigen expressing prostate cancer cells. Then there is radium-223, which is indicated for those that have symptoms from metastatic castrate-resistant prostate cancer involving the bones, but not to other parts of the body. There is a radioactive material that goes to areas in your bones that are growing quickly, and bony metastases are one of those rapidly growing areas. And then it gives off radiation that helps kill the prostate cancer cells. So in addition to docetaxel, we also have cabazitaxel as an alternate option for chemotherapy. So there are several myths which are debunked here regarding chemotherapy. Myth number 1, you are constantly vomiting and nauseated on chemotherapy. Well, that is not true. This is actually not very common. And if there is some nausea, there are available supportive measures to alleviate this. Number 2, chemotherapy is only a last resort. Not true. Definitely far from a last resort. Studies have shown that, much like some of the other newer agents we have available, chemotherapy can also be given early in the treatment process. And number 3, chemotherapy can kill the patient. This is extremely rare, especially with modern administration and close monitoring. And lastly, It is important to seek out a second opinion at key decision points during the disease journey. Now, this doesn't mean that you don't like or don't trust your physician, but by discussing your options again from someone else may actually just reinforce your ultimate decisions, so that way there is no looking back moving forward. It definitely takes a multidisciplinary team to help guide you in the best individualized treatment plan. So I appreciate your attention, and I know that was a lot to pack in within the hour, but I want to again thank Wendy, Lindsay, and the rest of the PCEC team for inviting me on to speak today. And I do think we now have some time for some questions.
Thank you so much, Dr. Pohlman. That was fantastic. And you did a great job putting a lot of information in there. So thanks for that. So we do have a couple of questions, and I'm going to start with some that were pre-submitted. The first one is, my PSA fluctuates between 3 and 12, and I've had a negative biopsy. What do you suggest as a next step?
Well, when we talk about prostate cancer screening, especially for men over 70, we have to take into account life expectancy. We will consider continued prostate cancer screening in men who still have a life expectancy of greater than 10 to 15 years. So this is where your physician can discuss the risks and benefits of prostate cancer screening, taking into account your age and what other medical problems that you have that could affect that life expectancy. But again, if you're still kind of in that range where the benefits may outweigh the risks, would be continuing to monitor that PSA in men that have already had a negative biopsy. One option would be to get an MRI to see if there's any lesions, especially if you're considering a repeat biopsy, to not only repeat the biopsy, but also target some of the abnormal lesions. And we also have different various biomarkers available to kind of help, supplement the PSA in determining if another repeat biopsy is warranted.
Excellent. The next question is, I am debating between radiation and prostatectomy. What do you think is better in terms of preventing cancer from coming back?
Great question. Well, they're both good and effective treatment options for the treatment of prostate cancer with really comparable success rates. So I can't say that one is better than the other. Again, which at times I think does make it hard for the patient, because at the end of the day, the patient will need to make the decision. You also have to take into consideration your overall risk of recurrence in looking at your risk stratification. For someone with a higher risk disease, they are going to have a higher chance of having a prostate cancer recurrence after initial treatment, whether that's radiation or surgery. And while it's not impossible to have salvage prostate removal after you've had radiation therapy, it does make it more difficult. So I have some men that choose surgery first, knowing that they have a higher risk of recurrence as their initial therapy. And if they have a recurrence, they can go back and do the salvage radiation therapy after initial surgery, that's if needed for a biochemical prostate cancer recurrence.
Thank you for that. That's very helpful. Another question is, if a patient has prostate cancer, when should their children or sons start getting tested?
Yeah, and this is another great question. Now, especially for men who have had, who have a family history of prostate cancer that developed at an earlier age, or a history of advanced disease, I think it's a good idea to go ahead and get a baseline PSA at age 40. Now, even in the absence of any family history, we are getting better available tools to help us determine, who we need to worry about more, considering early initiation of prostate cancer screening, as well as more frequent screening. Where tests are becoming available, looking at what's called a genetic risk score. And this is really different than BRCA testing. This is looking at blips in the DNA, or single nucleotide polymorphisms, and it really helps predict their risk of developing prostate cancer. And this is kind of where I'll make a plug for my Prostate Health podcast, I would definitely check out episode 33, where we talk about this in even more detail. And there's a link on the PCEC homepage that takes you to the podcast, or you can listen to it wherever you listen to podcasts, in Spotify or iTunes. So again, I think we're doing a better job of trying to determine a man's risk.
That's great. That's a difficult question to answer, so thank you. Another question is, how do you know if your primary treatment is failing? And this gentleman specifically had radiation, but I think the question would apply to both surgery or radiation.
Yeah. Well, when we talk about failing, we oftentimes it's referred to as a biochemical failure, or in the in surgery that's a PSA recurrence, and currently it's defined as a PSA of 0.2 or above on successive values. And in radiation therapy, there's different definitions, but essentially your PSA goes after treatment goes down to a low level and should stay there. But if it starts rising again on successive PSAs, that would be considered a failure as well. And then for somebody that has had, for example, if they've had radiation first, for a recurrence, you have different options, including continuing to watch, depending on your age and health, or choose more salvage therapies such as surgery. Or on the other hand, if they've had surgery first, their PSA becomes detectable, they'd have options, including salvage radiation therapy as well. But again, these are things that your urologist will be keeping a close eye on, and that's why it's important to keep your close follow up with your urologist, who will be keeping tabs on this and looking for these.
Great. And here's a question that we get kind of frequently is, what are your tips for managing hot flashes?
Yeah, that's a good question too. And that's a difficult one. Fortunately for most men, that does get better with time. But for those men that have the persistent, bothersome hot flashes, there's a medication called Megace that can work to help kind of blunt. It's not going to take it away completely, but I've had some men that find that it kind of blunts the hot flashes to the point where it's not as bothersome. And another option would be, I've even had some patients that have switched to a different hormonal agent that found that maybe they tolerated one different brand or different type of shot better. I don't know if that's kind of more kind of placebo effect or what, but I've had some men that do better on other shots than others. And there's also what we call intermittent androgen deprivation therapy. So usually when we place a man on hormonal therapy, it's more of a continuous therapy. But for men that are not tolerating the therapy, sometimes we'll consider a more intermittent form where we take you off of that the treatment, continue to watch your PSA, and at some point we may have to put you back on it, and then continuing to monitor that PSA.
Excellent. This gentleman said he just got a positive result for genetic testing. What should he tell his kids about their risk?
Yeah, and this is where I think it's very important to work closely with the genetic counselor that is, especially trained in this area, that can really help, first of all, determine what that positive test is and what it means. I'm assuming it's a BRCA test, but yeah, I think that's where, when it comes to that, I think us as a urologist, we can do a great job of determining, who needs these tests and helping interpreting those tests. But and again, when it comes to those conversations with family, and that's where I think it's very important that they seek the counsel of a genetic counselor. And a lot of the companies that offer these tests now do have genetic counselors that you can talk to, or talk to your doctor about the nearest genetic counselor that you can go see.
Great. And then we have a question on PSMA testing. A patient asked their doctor for it, and the doctor said it wasn't available. Is it hard to find, or is it so new that maybe it's not in every location across the U.S.?
Yeah, and I think we're probably going to be having some exciting news coming down the pipeline regarding PSMA, as well as the FDA approval. So stay tuned. But you're right; it's not as widely available, but I think that it will become more widely available soon, and and that's one that again, trying to help detect prostate cancer that's not being picked up on bone scans.
Thank you. And then this I'm going to use as our last question. We're almost at 4:45. There's a question about, do doctors get upset if you go and get a second opinion?
And that's a great question, because I know that, this is a, relationship that you've had with your physician. Oftentimes, um, they were the ones that were involved with your initial counseling for, process for the elevated PSA. They did the biopsy, they sat down with you and talked, so there is definitely a connection there. And definitely that's something that I actually encourage of my patients. And I think I would never be offended, and nor would any other urologist, for you to go and get a second opinion. Even if you decide that, the who you met with to get the second opinion is maybe a better fit for you and your situation. But oftentimes I see patients, coming back from that second opinion, just feeling better about just hearing it again from maybe a slightly different perspective, or just kind of, confirming what their initial thoughts were. Because again, it's a decision that you really need to look at all options, because you want to pick it. Once you choose an option, you want to move forward and not have any second doubts. Nobody wants prostate cancer, but the nice thing is, with prostate cancer, you do have some time to go and get those second opinions, and to really, research your options. That way, once you commit to a decision, just stick to it.
Dr. Pohlman, I have to ask one more question that just came in, because I think it's a really good one, and one that patients struggle a lot with. And you mentioned it briefly. When a patient is picking a primary treatment option, and so they're maybe looking between surgery and some sort of radiation, are there any tips or questions or thoughts that you could provide that might help them make that decision?
Well, I think one great question, and this is a hard question that I get from patients, is, what would you do, if this was if this was you or your family member? And that's a really tough one to, because sometimes I think maybe as a surgeon, I'm more biased towards surgery, or vice versa. A radiation oncologist might be more biased to radiation. But so that's definitely a good question, though, to kind of to gauge their response. But I think, again, you have to really, research all your options, and really the difficult thing with prostate cancer is there's not a one size fits all. What might be fit best for you may not fit best for somebody else. And so that's why you have to really look at all the risks and benefits of each option, and look at your own health. And, some patients that may want surgery may not be good surgical candidates, because of the, lung problems that would complicate anesthesia. And so everybody's situation is a little different. And so you have to really kind of, work with your physician, work with your second opinion physicians, to really find out, what's really going to fit your personal preferences.
Okay, I'm still not going to let you off because they keep rolling in.
Sure.
So another gentleman asked, he's on blood thinners for artificial heart valves. Could he consider surgery?
Again, it really depends on, what your cardiologist thinks is your risk, if you were to come off those blood thinners, because typically, to do a radical prostatectomy, that's not a surgery that we would be able to do with you continuing on those blood thinners. And so, you're with the help of your primary care provider, and likely your cardiologist too, they're going to have to kind of review your history. How long ago was it that you've had any treatments for your heart, and really kind of weigh the risks and benefits of coming off of that therapy. And for some, the risk may be too high. So.
And then, okay, this is really going to be our last one, I promise. Who does the follow-up when you're on hormone therapy looking for those side effects? Is it your primary care doctor, your urologist? Who really is the one responsible for monitoring you?
No, I think this is kind of where we get into the multidisciplinary team. It does take a team, and usually it's a combination of your urologist and your primary care provider together, looking at all these things, because I don't treat diabetes, and I don't treat heart disease, and so that's why I think it's important to have your primary care provider involved. Sometimes an oncologist is involved in that scenario as well, and the radiation oncologist. But it really is a team effort. So if you're going to see the urologist and you're getting these shots, I still think it's very important to, at the very least, make sure you're keeping close tabs with your primary care provider and monitoring your blood pressure and blood sugars and so forth. So.
Okay, and then we had one comment too about HDR brachy. Could you talk a little bit about that and how it might be different than regular brachytherapy?
Yeah, and that's definitely could be an episode on or a talk on itself, but it's a great question because I think where some get confused is that it's the HDR stands for high dose, but you're not getting a higher dose, it's a high dose rate. So you're just getting it over a quicker period of time. And actually, for that individual, this is another one where, a shameless plug, but we just had a great episode, episode 34, which was Understanding Internal Radiation Therapy, where we had radiation oncologist Dr. Ronald Chen, who's the chairman down at the University of Kansas, that basically answered that very question and did a great job of it. But yeah, it's still the same. We're kind of looking at the same dose, but they're temporary implants where they're put into the prostate for either overnight or for sometimes up to 2 days, and then those seeds are actually taken out. And sometimes it actually involves multiple treatments, whereas the low dose rate brachytherapy, you're getting that same dose, but it's permanent seeds that it's delivering radiation to that prostate over a longer period of time.
That's fantastic. Thank you so much, Dr. Pohlman. Again, I know we could be on here for another hour with the question and answer. So if anybody has additional questions or something that we didn't address the way you were hoping, please feel free to send us a note and let us know. We want to definitely thank our supporters for this webinar series, Dendreon, Myovent, Pfizer, and Astellas. We very much appreciate the support so we can continue these educational programs. And most importantly, Dr. Pohlman has a fantastic podcast, as he's mentioned. It's one that we all listen to, and I know a lot of the doctors we work with also enjoy. And you can visit that at prostatehealthpodcast.com. And you can also find that, as he mentioned, in Spotify or your Apple podcast app on your phones. And of course, you can always call us and we'll help you locate it as well. Dr. Pohlman, is there anything else? Did I give the best address for finding the podcast?
Nope, I think that's great. And Google's great too. You just search Prostate Health Podcast and you'll find it. But again, like I said, they're already going to be heading to the PCEC website anyways. So they can, because there's great resources there, but on your homepage, they can scroll down and find it there as well. So
Yep. It's something we're very proud of. And something that all of our council, which is all physicians from around the country, also support very strongly, and something that they refer patients to. So we're super excited to be able to share that with these folks tonight. So thank you again, Dr. Pohlman. We very much appreciate it. We hope you have a great Thanksgiving holiday coming up and very much appreciate your time.
You as well. And it's definitely an honor and a pleasure to join you here today. So
thank you so much.